Yeah.
I just walk up here and everyone becomes quiet. But I guess we'll get started then. So, good morning, everyone. Just one announcement. This is the last grant rounds for this academic year. As you know, next week is M&M. Then we'll take our summer break and we'll come back up in September. But this morning, it's my pleasure to introduce today's grand round speaker, Dr. Corey Ventetuolo. Dr. Ventetuolo is a physician scientist in pulmonary and critical care medicine here at Brown. She was just named the director of the Division of Pulmonary Critical Care and Sleep Medicine, and she's the inaugural director of the Center for Advanced Lung Care, an exciting new leadership role reflecting both her clinical expertise and vision for the field. She completed her medical training at Boston University School of Medicine, followed by residency in internal medicine and fellowship in pulmonary and critical care at Boston Medical Center, which is also where she developed her research focus. And currently, her work centers on pulmonary vascular disease with particular expertise in pulmonary hypertension and right ventricular failure. And as you can see, she'll be speaking to us about that today, which is a topic that is challenging and often frightening for us surgeons. Thank you, Dr. Ventetuolo.
Good morning, everybody. Thank you, Dr. Amy, and thank you, Dr. Pryor, and everyone for the invitation to be here this morning. It's a pleasure to speak to you. I'm going to try to sort of keep this to relevant areas for, I think, patients that you may encounter in surgical fields. I'm going to start just with my disclosures. First of all, I'm funded to do work in this area. This isn't a talk about most of my research, but I'll try to point out a few gaps in the field. Extracorporeal circuits are technically not approved for use for more than 6 hours outside of the operating room. So you should know technically when we do ECMO, most of the time it's off-label. I'll briefly be discussing off-label use of PAH therapy in the ICU. And then these are some of my industry-related disclosures. Okay, so the objectives for this morning are to briefly review the nomenclature that we use in pulmonary vascular disease, talk about some of the perioperative considerations for patients with pulmonary hypertension and pulmonary arterial hypertension. We'll spend a fair amount of time talking about how to manage right ventricular failure postoperatively, and then finally end with a few minutes on extracorporeal support, which I think we all have the opportunity to see at this institution in terms of both respiratory and cardiac failure. So I wanted to start by highlighting a couple of recent consensus documents that have been put out by ISHLT and up to the left there, and then to the bottom right, the 3CPR Council, the American Heart Association that I'm a part of, basically on perioperative management of these patients. So for any of you who may be interested in kind of doing a deep dive on this, these are the two, I would say, leading documents in this area. A lot of what is presented in these documents is actually not necessarily evidence-based. And so a lot of it is really consensus opinion. So just FYI. Okay, so we're going to start with two patients. These are actually patients of mine that I've seen over the years with pulmonary hypertension who need colorectal surgery. So the first patient has metabolic syndrome. He has moderate COPD. He has functional class 2 symptoms. His COPD is considered well controlled. He's had no recent acute exacerbations, and he's on standard of care for COPD. And his echo there, you can see on the bottom left, shows an enlarged left atrium, an elevated left atrial volume index, mildly enlarged and dysfunctional right ventricle, and an estimated right ventricular systolic pressure of 60 millimeters of mercury. The next patient is similar in age, 79, a history of scleroderma, and she has functional class 3 symptoms. No evidence of pulmonary fibrosis on PFTs or CAT scan, and has the same exact echo as the patient on the left. So just keep these two patients in mind, and we're going to come back to them in a bit in terms of how we might approach these individuals perioperatively as they look to their colorectal surgeries. Okay, so for those of us who may have not thought about the pulmonary circulation in a while, just sort of thinking back to medical school, what is the basic physiology of this circuit? So the pulmonary circulation is much different than the systemic circulation. So it is designed differently with a much denser capillary network, about 1/7 the amount of smooth muscle cells as compared to the systemic circulation. And as a result, has a much lower mean pressure on average. So 15 as compared to a mean pressure of around 100 in the systemic circulation. And so in the normal state, the pulmonary circuit is really built for low pressure, low resistance, but highly recruitable for flow. So when we do things like exercise, get septic, have increased demands from our muscles from working out, we can move a lot of blood flow through the pulmonary circuit and give oxygen, remove carbon dioxide, et cetera. In pulmonary arterial hypertension and many pulmonary hypertension disease states, the peripheral pulmonary vasculature is actually obliterated by what we call plexiform lesions here in the pulmonary arterioles. And so this dropout of the peripheral circulation over time results in an increase in pulmonary vascular resistance, high pulmonary pressures, and then ultimately right ventricular failure. So I wanted to do a little bit of sort of review of how we define these patients when we see them. So what do we define as pulmonary hypertension? These hemodynamic thresholds changed about 7 years ago in the field to reflect what is really twice the upper limit of normal. So pulmonary hypertension is defined hemodynamically by a mean PA pressure of greater than 20. And then we think about where the abnormality is. Is it precapillary pulmonary hypertension, meaning existing in the lungs? So left heart filling pressures are low. Is it postcapillary, meaning coming from the left heart? In other words, left heart filling pressures are high. Or is it a combined picture with both elevated PA pressures and pulmonary capillary wedge pressures? And then in all cases, a pulmonary vascular resistance higher than 2 Wood units is considered abnormal or to be consistent with pulmonary hypertension. However, this really remains a diagnosis that we make clinically. And so you can see here on the bottom, we still think about things in terms of 5 major subgroups of pulmonary vascular disease, group 1 through 5. Group 1 is the artist formerly known as primary pulmonary hypertension, now referred to as pulmonary arterial hypertension, and includes things like idiopathic disease, drug and toxin related, et cetera. Group 2 is left heart disease from any left heart abnormality, HFrEF, HFpEF, valvular heart disease. And these individuals can have a post-capillary hemodynamic picture as well as a combined pre and post-capillary hemodynamic signature. Group 3 is lung disease or chronic hypoxia. Group 4 is chronic thromboembolic pulmonary hypertension. And group 5 is diseases that are either have multifactorial insults to the pulmonary circulation, such as sickle cell disease, or they have unclear mechanisms in the way that they cause PH. So PAH remains very rare here, pictured all the way on the left. And so when you see these individuals, until proven otherwise, this is usually due to left heart or lung disease, so group 2 or 3 pulmonary hypertension. We estimate that about 1% of the global population has PH, but again, most of these individuals will have chronic heart or lung disease. So it becomes our job, the pulmonary hypertension experts, to really sort out, what the etiology is due to and how to manage these patients, since this has become increasingly complex, as I'll get to in a moment. So again, PAH remains rare. Group 1 prevalence is about 15 cases per million in terms of idiopathic individuals, meaning no identifiable cause, with an incidence of 2.4 per million per year. We are a center of excellence here, and so we do see a disproportionate number of these individuals. But as surgeons, you will come across this rarely in your career. When you look at group 1 sort of etiologies, about half of these individuals will have idiopathic disease. The other half will have associated conditions. And associated conditions for you all to be aware of include things like congenital heart disease. So certainly cardiac surgeons have to contend with these patients a lot. Also portal pulmonary hypertension due to liver disease. And this is something that we see work up and can be an exclusion for liver transplantation. And so in liver transplant centers, this can be a big issue. So when we're first meeting patients, and then certainly when we're evaluating patients for the perioperative period, we sort of talk to them a lot about clinical history, some of their risk factors, form a clinical suspicion, use a bunch of non-invasive tests, including things like echo, which remains the screening test of choice for pulmonary hypertension, pulmonary function, CAT scans, et cetera. But then the final piece in the diagnostic puzzle needs to be right heart catheterization, since this is a disease that still remains diagnosed and defined by hemodynamics. And so right heart catheterization is usually the sort of major decision point to make when you're evaluating a patient for surgery is whether you need to update hemodynamics and optimize them based on those values. So this is not meant for you to really study in great detail. It's really meant to illustrate the tremendous progress in this field since 1995. So we've had 16 drugs approved for group 1 pulmonary arterial hypertension. And now we have drugs approved for PH and interstitial lung disease, as well as chronic thromboembolic pulmonary hypertension. So this has been really one of the reasons why I've chosen to focus my career in this area, is that it's been tremendous progress informed by the biology of disease. And it's been a great pleasure to see patients go from having really, frankly, a survival of 2.8 years to now patients we have living for decades. So that said, these regimens get incredibly complicated, and I'll get back to this in a few minutes. When we see these patients perioperatively, it's an opportunity for us to avoid harm by making sure that they remain on these medications and thinking about titrating them carefully after the OR. I wanted to just have a brief aside about our CTEPH program here, because I think this is a great example of how we've had wonderfully productive collaborations with surgery and other departments, including interventional cardiology, radiology, and anesthesia. So we identified a need and 2 years ago started a comprehensive CTEPH program. This is a field that's evolved quite a bit, and we're now doing both balloon pulmonary angioplasties and also pulmonary endarterectomies. This is a enormously complex surgery. It requires deep hypothermia and complete circulatory arrest. And I just wanted to show you, these are some of the specimens that Dr. Soda has gotten from our patients thus far in our CTEPH endarterectomy program. And so far we're having great results. And it's been a great pleasure working side by side with members of CT surgery, anesthesia, and others. Okay, so getting back to sort of perioperative risk in PH, I wanted to highlight some key findings from the available studies, acknowledging that these studies really are based on retrospective reviews, case reports, large series, et cetera. So this covers a span of sort of the late 90s to the early 2020s. The reported hemodynamics in these patients typically average mean PA pressures between 40 and 55. And in some severe cases, PA systolic pressure is up to 100, which if you remember back to the beginning of the talk, normal mean PA pressure is about 15. So quite elevated PA pressures. This is mostly non-cardiac procedures and mixed anesthetic approaches, including general, regional, and MAC. And really what's emerged from this literature is that there is no universally safe technique to approach these patients operatively. In terms of mortality, again, this is potentially subject to a lot of reporting bias here, but mortality ranges between 0 and 35%. In more contemporary cohorts with modern treatments, mortality is lower, around 3 to 10%. And of course, this is higher with patients with severe pulmonary hypertension, those that require emergent surgery, and patients who go in with RV failure. The major drivers of morbidity in this group, which can be quite common, is RV failure, respiratory failure, and prolonged mechanical ventilation, and then things like arrhythmias, myocardial ischemia, acute kidney injury, and sepsis. So the take-home point from, I think, the literature to date is that the perioperative risk is substantial for these patients and driven primarily by RV failure. So we're going to switch, in the talk to talk a lot about managing RV failure because I think we think about it certainly post-operatively and going into the OR with our surgical colleagues. So this is a nice schematic from that ISHLT consensus document I mentioned at the beginning of the talk. I think a lot of this is obvious, but key perioperative questions to think about are: what are the benefits of surgery versus not? Is this patient medically optimized from a pulmonary hypertension? What is the urgency of surgery? Where should the surgery be done? And so this is a discussion we have a lot because we usually need for our more severe patients, cardiac anesthesia and certainly ECMO as a backup. What is the intra and postoperative monitoring plan? Where will these patients be recovered? Is the patient a candidate for ECMO? We'll talk about that in a few moments. And then what's the plan for managing their PAH regimen, given the complexities that I highlighted a few minutes ago? And so this really takes a lot of collaboration and multidisciplinary meetings hopefully in advance of the planned surgery. So the PH team, anesthesia, the surgeon, the surgical team, of course, and then the ICU where the patient's going to be recovered. So if we go back to the two patients with PH who we sort of presented at the beginning, remember they were very similar except had different risk factors, but had the same exact echoes. So how do we approach these patients? So in this individual, it's sort of fairly obvious that their pulmonary hypertension is due to their chronic obstructive pulmonary disease, and their RV is mildly enlarged, mildly dysfunctional, but they have only functional class 2 symptoms. So in this individual, we would complete non-invasive risk assessment, meaning is their COPD optimized? What does their echo look like? Do they look clinically like they're an RV failure? We diagnosed him with sleep apnea. We started him on CPAP before the surgery. We upped his diuretics. He improved and his echo actually normalized, which we see quite often in these types of patients. And so we deemed him sort of optimized to go forward with colorectal surgery. We also, obviously met with our surgical colleagues, and it was deemed sort of an elective case. And so we had time to do all of these things and get him ready for the OR. The patient on the right, we were much more concerned about because of the risk factor for group 1 pulmonary arterial hypertension, having connective tissue disease and obviously more advanced dyspnea. And so this patient underwent right heart catheterization. We diagnosed her with PAH. We started her on specific PAH therapy, 2 oral drugs, and her symptoms improved. Her echo remained mildly abnormal. And so in this case, to prepare for the worst, we basically planned for cardiac anesthesia in the OR and then inhaled nitric oxide to be added perioperatively, as well as ECMO sheaths placed for this patient. And she did fine. She had sheaths in place, did not require ECMO, but this is the kind of planning that it really takes, I think, to set everybody up for success. So I wanted to pivot now and talk about RV failure. This is really the major determinant of outcome in both PAH and pulmonary hypertension, irrespective of cause. So no matter the World Symposium group here, really how your right ventricle responds to that increased afterload and pulmonary vascular resistance in the lungs is going to determine how the patients do. And we still understand very little about how the RV adapts. So we have patients who have what we call adaptive remodeling and do quite well over time, while we have other patients who really kind of fall off the cliff, have PA to RV uncoupling and do poorly. And so managing the RV around the OR becomes critically important. I just wanted to take a minute to talk about the right ventricle. It's the forgotten ventricle, if you will. It's the most important ventricle. It is not the left ventricle. It's designed entirely differently. So it's custom built to maintain perfusion of the pulmonary vasculature. It's really, we learn in medical school that the RV is preload dependent. PH docs hate that because everyone somehow conflates that with give fluids all the time. It's just exquisitely sensitive to changes in afterload and built for sort of preload. And so if you look at, this is banding models where you take the left ventricle and you band the aorta, the LV is obviously able to sustain these increases in afterload quite well in terms of stroke volume, while the RV, after you band the pulmonary artery, really falls off a cliff and stroke volume is rapidly reduced with that increase in pulmonary vascular resistance. So when we think about patients going through sort of a time course who develop RV compensation and then decompensation, over time, pulmonary vascular resistance is increasing, and that is okay as long as the RV can keep up with it. So we see a rise in PA pressures until finally the RV becomes decompensated and uncoupled from the pulmonary artery, and cardiac output then starts to decline with a rise in right atrial pressure. When we see patients on this end of the spectrum, this is when we become pretty concerned. And so you can imagine patients with congenital heart disease, for example, who have a lifetime for their RVs to accommodate these small changes in pulmonary vascular resistance over time, tend to do better than patients who have quite rapid escalations in PVR. So, for example, large pulmonary emboli. And so some triggers for RV failure in both PH and PAH include therapy withdrawal, diuretic withdrawal, volume overload, and perioperative decompensation. And these are highlighted here in this sort of top box because we've seen this happen in some of our patients who go for surgeries, emergent or elective, is that, the pH therapy gets stopped inadvertently, the diuretics are held, a lot of volume is given perioperatively, and then they do poorly. Pregnancy is a major issue for us, and this remains sort of a shared decision with patients whether or not they can become pregnant. Infection and sepsis, cardiac arrhythmias, PEs, and also hyperthyroidism can really unmask RV failure in our patients. So to talk a little bit about overall goals for managing right heart failure perioperatively or in the ICU, we'll sort of think about this in 6 major buckets. 1, optimizing RV preload. 2, avoiding RV ischemia. 3, decreasing RV afterload. 4, reversing triggers for decompensation. Enhancing RV contractility or efficiency. And then finally, extracorporeal life support. So I'll go through each of these sort of topics here. So first, optimizing preload. So this is the Starling curve for the RV, and it's very long and flat as compared to the left ventricle, as I mentioned a few minutes ago. And when you have a patient who has chronically high afterload from increased pulmonary vascular resistance or RV dysfunction due to decreased inotropy, this curve is shifted downward and becomes even more flat. And so augmenting stroke volume with fluids, for example, is really going to be injurious for these patients. So you're just going to push them further along this Starling curve and ultimately off the back end. And so ideally, our patients, the sweet spot tends to be a right atrial pressure, for example, of 10 to 12, CVP of 10 to 12, certainly not any higher than that. And this comes from a lot of animal work that's been done, similar models where the pulmonary artery is banded. This is a large animal model. You can see here stroke volume, cardiac output, and systemic blood pressure. And this is the normal state where you see, obviously you want to increase stroke volume, you give some volume to the patient, and their stroke volume increases, their cardiac output increases, and their blood pressure is also augmented. If we return these animals here back to baseline and then band their pulmonary artery and now give fluids, this will result in an increase in their pulmonary vascular resistance, a decrease in their cardiac output, and a fall in their systemic blood pressure. So really, again, under that chronically high afterload state in the lungs, giving volume tends to push patients, and in this case, large animals, off the back end of their Starling curve. Second, we want to avoid exacerbating a right ventricular ischemia. And so in a chronically overloaded RV, these individuals become reliant, their RVs become reliant on diastolic perfusion pressure, whereas in the normal state, the right coronary artery is perfused throughout systole and diastole. And so it's really critically important when the pulmonary vascular resistance outstrips the systemic vascular resistance that we keep patients' systolic pressures high. And so typically we use vasopressors very generously in these patients. The second reason to do this is to try to increase LV afterload by giving peripheral constriction and try to minimize what we call intraventricular dependence, which is as the RV becomes dilated and dysfunctional, there's interseptal dysfunction and bowing of the septum into the LV, thereby limiting cardiac output in that way. So we get this question a lot, what's your choice of vasopressor? And really there's no great data on this, but I would say what intensivists pull from all the time is this SOAP2 trial, which studied all forms of shock and looked at norepinephrine, it was a randomized control trial looking at norepinephrine versus dopamine. And you can see here that norepinephrine clearly won sort of the day, including in cardiogenic shock patients. And so while this hasn't been robustly studied in PH, norepinephrine tends to be our pressor of choice in these patients with RV failure. Okay, so what about reducing afterload? So I wanted to talk a little bit about pulmonary vasodilators and what we may use in patients who have to undergo surgery. So first of all, many of our patients for the epoprostenol analogs are on either infusion type therapies or inhaled type therapies, which are not things that we tend to see every day. And so not in this institution, but in others, we have had patients show up with pumps that are assumed to be insulin pumps, for example, removed, taken to the OR, and died perioperatively because of withdrawal of these medications. So that's sort of why I sort of said we have to run the med list and be familiar with what these medications are to make sure that patients are continued throughout their operative course. So in terms of, rescuing or supporting these patients through surgery, we use IV prostacyclin almost primarily in patients who are very sick. These drugs are dosed in nanograms per kilo per minute, and so they require pretty exquisite nursing support in terms of making sure that patients aren't receiving boluses of these drugs and or withdrawal, because just a small change in volume administered to these patients can be hemodynamically devastating. We will also use inhaled prostacyclin analogs, including nitric oxide and epoprostenol. We tend to use PDE5 as well. We have to consider, obviously, in certain patients what their gut absorption is doing, especially perioperatively, and we always prioritize systemic blood pressure. All of our drugs tend to cause systemic hypotension. So depending on how a patient's doing clinically, we may, reduce the systemic PAH therapy, add an inhaled pH therapy to avoid systemic hypotension, and then use pressors in the background to support a patient. So again, these things we don't see every day. When you do see them, I would say that if you remember nothing else, the advice is to call the PH team here. So sudden withdrawal of pulmonary vasodilators can be very, very serious, as I mentioned a minute ago. And there are case reports all over the literature when nitric oxide, for example, is acutely terminated in patients who are supported with this perioperatively or while in the ICU. If you take patients without pulmonary hypertension or normal individuals and you give them nitric oxide, it has a vasodilating effect. And so just stopping it will cause rebound in pulmonary pressure. So if you do this in a patient with pulmonary hypertension, it can be quite devastating. And so we typically are involved and manage this, wean this stuff very, very slowly and or augment therapy depending on how the patient is doing. We do use a lot of inhaled nitric oxide, particularly in the perioperative period. This is very potent medication. It's inactivated by hemoglobin in the pulmonary capillaries, so it's very quick on, quick off without systemic effects. There's a lot of literature in the cardiovascular surgery realm that shows that this helps patients who have acute RV failure post-cardiotomy with improvements in hemodynamics and RV function. So certainly, it's used a fair amount in the cardiothoracic ICU. Finally, moving to enhancing contractility. So again, in the ICU, we get a lot of questions about if you're going to use an inotrope, which one do you prefer? And the two major choices are sort of dobutamine versus milrinone. Very briefly, we tend to grab dobutamine when it's isolated right heart failure because there's less systemic hypotension, particularly at lower doses, and it has shorter half-life. When patients have biventricular issues, so biventricular heart failure, we tend to reach for milrinone. I realize that, milrinone has a pulmonary vasodilatory effect, and I think for that reason, anesthesia tends to really like it, but you can get into issues with hypotension in patients with isolated right heart failure. So we tend to reach for dobutamine first in these patients. So when we talk through sort of guidelines for anesthesia and with our surgical teams, if possible, we'd like to avoid general anesthesia. Mechanical ventilation can be pretty injurious for our patients because of shifts in preload and afterload. Obviously, better to do elective than emergent surgery, avoiding systemic hypertension, as I mentioned, using vasopressors, having them at the ready peri-intubation. I realize this is hard for a surgical crowd to hear, but we really do not like to give fluid unless we have to. We have also a fairly dogmatic avoidance of propofol in these patients because of the risk of systemic hypotension. We give, as I said, INO pretty readily. And then finally, thinking carefully about when we introduce potential ECMO as backup. Not every patient of ours needs a PA catheter at the time of surgery, but what we want to think carefully about is if we should update hemodynamics going into surgery to know exactly what we're dealing with. In very few circumstances, really, unless it's cardiac or thoracic surgery, do we make real-time decisions based on hemodynamic values because they're fraught with error. But we do often do this as an outpatient or, sort of semi-elective inpatient just prior to surgery to make sure that we don't need to augment PAH therapy further. We like to have an A-line placed in all of our patients, and then we monitor things like CVP, central venous oxygen saturation, and lactate pretty carefully in our patients. And then obviously both intra-op TEE and post-op transthoracic echoes is pretty important to see what the right ventricle is doing. All right, so we've been through sort of these 5 topics now, and I wanted to switch for the last part of the talk to extracorporeal life support. I see Dr. Lux in the audience. He drew this picture, so thank you. So this is a review from many years ago that Dr. Muratori and I both wrote together for the Blue Journal. And I think this is familiar to most in the audience, but I'll go through this quickly. So this is the extracorporeal life support alphabet soup, if you will. So in most circumstances, this is going to involve draining blood out of a major vein, running blood through a centrifugal pump, particularly in adult populations, a membrane lung or oxygenator, and then returning blood back either to a vein or an artery. And so when we do this combined with CPR, we call this CPR, extracorporeal CPR. When blood goes back to a major artery, usually the femoral artery, this is VA ECMO to provide hemodynamic or cardiac support. When we go back to a major vein, either the femoral vein or the internal jugular vein, usually, this is veno-venous extracorporeal membrane oxygenation. We can also do ECOR. This is really carbon dioxide dialysis for the lungs, which can be achieved in different configurations. And then, I will say surgeons have thought up all sorts of ways to combine ECMO circuitry and platforms. And so we are now doing things like triple and quadruple configurations to support patients with variable amounts of both heart and lung failure. All of this is obviously modifying the traditional cardiopulmonary bypass circuit outside of the OR, and doing this for any period of time from days to, in some cases, months. Patients are supported on extracorporeal life support to bridge them to heart-lung transplant, for example. All right, so switching gears now to think about 2 consults for pulmonary hypertension and extracorporeal life support. So this is a TICU consult, a patient who was in a motor vehicle accident, developed post MVA ARDS, was treated with standard of care, low tidal volume ventilation, was hemodynamically stable, but had an echo with a severe RV dilation, severe dysfunction, and an RVSP around 80. Contrast this with an OBGYN consult, a 30-year-old woman with connective tissue disease who showed up 27 weeks pregnant with syncope and very severely abnormal hemodynamics with a PVR of 26 Wood units. If you remember back, I said greater than 2 is considered to be pulmonary hypertension. So a very concerning situation on the right. So thinking through perhaps how we would support these individuals and when. This schematic here in the background is known as the vicious cycle of RV failure or the RV death spiral. And so, once pressure and volume is increased on the RV, as we've been talking about, you get increased RV wall stress, RV dilation, tricuspid annular dilation, and then these things all feed forward into each other until the LV is finally impacted by intraventricular dependence. And then ultimately systemic cardiac output is decreased and cardiogenic shock or obstructive shock ensues. And so people who are interested in ECLS have thought about when to introduce it in this RV failure cascade. Should we be early here when the RV has not fully failed? And I think really this is the scenario that occurs perioperatively, potentially, when we can use ECMO or ECMO backup to support some of these patients through surgery. Traditionally, this is when we usually intervene, is when a patient is in cardiogenic shock and not perfusing end organs despite things like inotropy and vasopressors, augmented pulmonary hypertension therapy. And so when exactly to introduce this is still unclear. But again, in patients undergoing surgery that they need, I think this can be a useful tool. But we need to have a conversation first with most patients about destination. So this is a schematic really meant for patients with PH and RV failure, but I really think it applies to patients with severe PH of any form, is that whenever we're thinking about using extracorporeal life support as a backup, we need to be having a conversation about destination first. So are you trying to bridge the patient to recovery or transplant? And if you're not sure, then it's sort of what we call a bridge to decision. And you have to have pretty candid conversations with patients and their families about this in advance. because you can strand patients on this support therapy, and it can be quite difficult then to withdraw that potentially in a patient who has no options. So destination first conversations, being clear in terms of the multiple disciplines involved about where you're headed. And then deciding on the specific configuration that's ideal for the given patient. So in terms of VV, traditional VV ECMO or pulmonary support, so this will provide only real gas exchange, does not provide any direct hemodynamic support, may help the right ventricle by reducing afterload. So when we put patients on VV ECMO, we put patients usually on lung rest settings on the ventilator. And so this helps to sort of improve afterload, augment preload. And we will think about this in patients who have mild, quote unquote, secondary pulmonary hypertension. So those with chronic heart or lung diseases, that their pH is not really acting more like PAH. And certainly we use this in ARDS with associated RV failure. Cardiac support. So this is where we can provide anywhere from partial to complete hemodynamic support, depending on the way in which a patient is cannulated. This is really patients who have the severest forms of pulmonary vascular disease, and certainly neonatal and pediatric indications include congenital diaphragmatic hernia, persistent pulmonary hypertension in the newborn, group 1 PAH, patients who are hemodynamically unstable from PE, and then obviously post-cardiotomy is when you want to think about traditional VA ECMO. Some of the alternative configurations I will get to in a moment here. I'm not going to talk about them in detail today. So how we might approach this in a PAH patient is, first medical optimization using the tenets that we sort of went through. So optimizing preload, which usually comes to either diuresis or CVVHT for fluid removal, avoiding RV ischemia by using vasopressors, augmenting PAH therapy, using an inotrope to support contractility, and then reversing triggers. So optimizing things like mechanical ventilation, treating infection, et cetera. When that fails for our most severe patients, we advocate heavily for awake ECMO because, as I mentioned a few minutes ago, the act of intubating a patient with severe disease can actually be terrible, result in immediate hemodynamic collapse. So this is a patient of ours that we years ago now bridged to lung transplant. We did a awake ECMO in this institution, and the patient was actually med flighted to Cleveland Clinic, received a lung transplant. She remains a patient of ours today. This obviously causes a lot of sort of consternation in the room when we do it, but it really is the best thing for patients hemodynamically with the most severe forms of RV failure. And so once a patient is on VA ECMO, we continue to think about the same sort of basic buckets that I outlined. We usually ultrafiltrate them. We will stop vasopressors so that their heart can sort of rest and be supported fully with the circuit. We, depending on if the patient is being bridged to transplant or bridged to recovery, will either stop PAH therapy or augment it. We will stop inotropes for the same reason, to avoid kind of flogging the RV, and then we will keep them awake, as I mentioned. I just wanted to point out that what I'm talking to you about, really, there's a huge evidence gap. So while we have good data now, randomized clinical trial data that I'm not going to present today, supporting the use of VV ECMO for severe ARDS, we really don't have complementary data using ECMO for cardiogenic shock, for example. And so these are two major recent cardiogenic shock trials that were done. ECLS shock, this was used in patients who had reperfusion therapy for acute MIs, and then they were given actual usual standard of care versus early cannulation and support with VA ECMO, versus this other trial, ECMO cardiogenic shock, which were patients, again, with primary cardiogenic shock, usually from ischemic heart disease, who were managed conservatively with medical therapy versus early VA ECMO. And you can see here totally overlapping sort of Kaplan-Meier curves, that really there's no clear benefit from the early use of VA ECMO in patients with cardiogenic shock. The use in PH and RV failure is an even larger gap. This is really limited to case reports and series and sort of consensus opinion at this point. Okay, so possible clinical scenarios for surgeons to think about when we might bridge to recovery. Really, these are the patients that we've been talking about this morning, which are those that require elective or emergent surgery or a major procedure, and trying to get them through that to recovery. And then in the last few minutes, I just wanted to discuss a few things about lung transplantation and how ECMO has impacted how lung transplantation is approached. So this is a sort of landmark report at this point that came out some time ago from colleagues, my colleague Marius Hooper and his group, where they looked at patients who were perioperatively supported with awake ECMO after lung transplantation versus mechanical ventilation, historical mechanical ventilation control group. And what they showed is that those who were kept on awake ECMO after bilateral lung transplant, they required shorter postoperative mechanical ventilation and hospital lengths of stay. This really tended to be driven by patients with PAH or CTEPH, so patients who had awake ECMO around the time of lung transplant tended to have were more likely to be kept awake and had higher elevations in their PA pressure. So this really changed the field in terms of people starting to think about the use of ECMO more liberally around the time of lung transplantation. Around the same time, people started getting surgical fields started getting sort of creative in how we can use novel configurations to support patients bridging to transplant. And so the most common bridge has been a pulmonary artery to left atrial connection, where we can, shown here, this is sort of deemed the nova lung. It requires median sternotomy, but patients can be supported like this for potentially months going into lung transplantation or heart lung transplantation. And with very low flows here, 2 to 3 liters per minute, you can maintain cardiac output. So PA to LA configurations is very common. What's now emerging is venopulmonary configuration, or oxy-RVAD. And we can use this in combination with 2 venous cannulas to potentially avoid pulmonary circulatory overflow. So oxy-RVADs are becoming increasingly sort of popular. People have bridged patients to lung transplantation who may have a PFO or an ASD by using VV ECMO configurations and basically directing the oxygenated perfusate blood through an ASD. So using that shunt that's already in place to oxygenate it and provide RV support in that way. And then in patients who are bridging to thoracic organ transplant, people have advocated for upper body VA ECMO configurations so that people can rehab while they're waiting for their transplant. So get out of bed and walk, for example. So this has become quite a hot area. And then the final point I wanted to make here is that actually lung transplantation is now being done in many places. Instead of on sort of traditional cardiopulmonary bypass, ECMO is used throughout the operation and then post-operatively to recondition the left ventricle. So if you think about this concept of intraventricular dependence, over time, the septum is sort of sitting in the LV. The LV can develop this relative diastolic dysfunction from being chronically underfilled. And through a lot of studies that have been done, we think that this contributes to primary graft dysfunction after lung transplantation, sort of a form of pulmonary edema where you put in, new lungs, the RV suddenly is exposed to a lower pulmonary vascular resistance than it's seen in a while. So it starts really augmenting stroke volume, and the LV sees a big cardiac output that it hasn't seen previously. And with this relative diastolic dysfunction causes passive congestion into the lungs and a pulmonary edema that we think contributes to graft dysfunction. And so you can see here, these are patients, this was done initially in Vienna and is now done in many places, coming out of lung transplantation where their left ventricular ejection fraction declines post-operatively. And by using ECMO and carefully titrated flows, they can actually sort of over time more gradually fill the LV and sort of help to recover this diastology that occurs because of long-standing pulmonary hypertension. No controlled studies on this. I think that lung transplant surgeons have just adopted this technique to minimize PGD over time. And so just to go back, completing this extracorporeal life support topic, I wanted to think about these 2 patients that I presented a few minutes ago. So the TICU consult with ARDS, and severe PH by echo. We supported this patient with VV ECMO in this circumstance. Their RV function we thought was just secondary from severe ARDS, and by achieving better gas exchange and minimizing mechanical ventilation, we felt like we could get away with VV ECMO. Venopulmonary route would also be a reasonable configuration for a patient like this. Obviously, in the patient who was pregnant, to support her through pregnancy, we would use VA ECMO. And so just to wrap up, I hope I've convinced you that this landscape has become pretty complicated. There are many perioperative considerations for patients with pulmonary vascular disease. We are here to help and work collaboratively with you. The RV really can be managed by thinking about these discrete buckets of preload, afterload contractility and addressing and citing triggers. And then I think, using extracorporeal support as a tool, if not actually going completely on ECMO, but using sheaths whenever we think about it to rescue patients who get in trouble perioperatively, I think has become one of our go-tos. So I want to wrap up by thanking particularly my partners in the ECMO program, Dr. Soto and Montevideo. They've been wonderful collaborative partners. And these are some of the folks that do both the clinical work and research at the institutions here and at other institutions in my funding sources. So thank you.
No. Questions? Dr. Harrington.
Good morning.
Monahan, please.
Great talk, Dr. Ventetuolo. I think the really extreme ones, when they come in on the fancy pH medications, those ones we can manage. The ones I think we struggle with the most are the ones that are not at that point yet, but they have it. And it's like, they don't have a PA cath yet, but they have some symptoms. And the real problem is, there'll be some people will say, get a cardiac anesthesiologist, and the cardiac anesthesiologist is like, we don't need to do anything about this. This is mild. But then the non-cardiac anesthesiologist will cancel the case. So it's like, how do we deal with that in between where they have symptoms, but they're not on multiple medications, they're not seeing you guys regularly, they're kind of like in this weird phase where you see it in the history and the anesthesiologist gets a little concerned, but there may not be much to do.
Yeah, I think those are tough. And we've had some conversations about these very issues with anesthesia, both cardiac and not. And I think there's no real answer except to say, like, we are happy to be called at any time and be involved. And we don't, it's got to be a discussion. I think everybody kind of takes last case bias, like the last patient I saw with this, died perioperatively. So we always err on the side of being more conservative. So we tend to really say, without thinking about resources, honestly, like this patient should be, have cardiac anesthesia. But oftentimes after a collaborative discussion and sort of, well, let's update the echo can be hugely helpful. If the echo can get updated and the RV looks okay, then we can often sort of meet in the middle of, okay, maybe they don't need cardiac anesthesia, but they'll be followed by PH pretty carefully post-operatively or something like that.
And I just wonder, is there a way to get like a champion on the anesthesia side as the person to say, this is the person when you have someone with PH, go to this person so that they can do a cardiac anesthesia assessment and then decide whether to.
Yeah, we've been working on that is the short answer, is to try to have a point of contact to sort of run these cases through. And they've been very responsive. I just think it takes bringing, everybody up to speed on when do we need to be concerned versus not.
Actually, sorry, Jared, because I just want to add on a little bit to that. It was kind of related to my question, these kind of unusual circumstances, but I was even thinking about, in our world, about cases that are emergent, need to go within, 1 to 3 hours of perforated ulcer or something like that. Is it fair to say, for our working plan, cardiac anesthesia, minimize fluids if possible, line up before OR, inhaled nitric oxide, should that be also a phone call to the pulmonary hypertension team as well too?
Yeah, and we use nitric oxide. We throw everyone on nitric oxide because it's easy, it's quick on, quick off. The thing we can't, the thing that's bad is if people like, okay, the case is over, let's stop it. That can be really detrimental to the patient. But yeah, no, that's a fair, I think, algorithm.
Sorry.
Great talk, thanks. Once a year, twice a year, we stumble upon a person that unrecognized pulmonary hypertension, and we discuss it at morbidity and mortality conference because the patient doesn't do well very actively. So what is a poor country general surgeon going to do about this? So what are the warning signs that this is not just a little COPD, chronic pulmonary disease? This is pulmonary hypertension we should be worried about. So how do we screen for this in a safe way? Not be too alarmist, but what should we be looking for?
Yeah, so at the end of the day, the two most, or I would say three most useful things are, a dyspnea assessment, functional class, like NYHA functional class. How short of breath are you? Is it with your routine activities? Is it with more exertion than that? Or are you short of breath at rest? And anyone who's got clear functional class 3 symptoms, I would be concerned. The echo can be, very, very helpful and needs to be within the past couple months. So I think oftentimes people are going based on an echo from a year ago. And then finally, just the clinical exam. If someone's coming in with lower extremity edema, that should raise a red flag. Like, is there something more going on? We also use NT-proBNP in right heart failure as much as we do in left heart failure.
Are all echoes the same?
No. Nope.
So.
Nope. And the pulmonologist.
Into our heads at the M&M. So
Yeah.
what are we looking for in echo? What should we be doing?
Yeah, and we also have saying that the road to hell is paved with echoes. So as much as I said, use it, like it's also problematic. There's a lot of variability. There's inter-reader variability. You cannot get great windows in a lot of our patients. But if you see that the RV is not so much dilated, but dysfunctional, and TAPSE is another measurement that we rely a great deal. So tricuspid annular plane systolic excursion, when the TAPSE is below 18, that should raise a red flag. PA systolic pressures, it's an estimate, but it's sort of, I know it when I see it type of thing. If the PA systolic pressure is above 60, that really will raise a red flag because the RV can't mount that pressure acutely. So that really indicates that more than likely than not, there's a chronic process. So in acute PE, for example, if you see a PA systolic pressure on an echo of 100, that should make people really concerned.
Any other questions?
Corey, what are the classic mechanical ventilation errors one can make with these patients if you do end up having to intubate them?
Yeah, that's a great question. High PEEP can cause pulmonary vascular sort of constriction, so it increases PVR. There's a sweet spot for tidal volumes, so above or below which will drive PVR. Hypoxemia and hypercarbia also drive PVR. So things like permissive hypercapnia that we would do with our traditional ARDS patients, we don't worry about, pHs of 7.2, PCO2s of 60. In pulmonary hypertension, we would want to try to normalize that as much as possible. And then, sort of peri-intubation when there's rapid intrathoracic pressure changes can really just cause people to code. So tidal volumes, 8 cc's per kilo, not super high PEEP, keeping oxygenation and ventilation adequate.
Any questions in the chat? Thank you very much.
Thank you.